Yeah, very clear.
Right, sir. Right, sir. Thank you, sir.
Assalamu alaikum, everyone. It's 11 a.m. sharp, and both our esteemed professors, Professor Muhammad Ali Khan and Professor Tahir Masood, has also joined us. Before we start our webinar, I would request everyone to keep their mics mute for better learning experience. In case of any queries, you can post it in the chat box and we'll try to answer it in the end. I welcome you all on the behalf of Department of Pediatrics, King Edward Medical University, and the Pakistan Pediatric Association Lahore chapter on the webinar on dengue infection in children, keeping in view the rising dengue case. We will begin our proceedings with recitation from the Holy Quran, and for this I will request Hafiz Zubair Bhutta.
Assalamu alaikum. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم لو أنزلنا هذا القرآن على جبل لرأيته خاشعا متصدعا من خشية الله وتلك الأمثال نضربها للناس لعلهم يتفكرون هو الله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم هو الله الذي لا إله إلا هو الملك القدوس السلام المؤمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور له الأسماء الحسنى يسبح له ما في السماوات والأرض وهو العزيز الحكيم صدق الله العظيم.
Shukriya Zubair, Jazakallah. Thank you. We have our two esteemed professors with us in our panel of experts, Professor Tahir Masood and Professor Muhammad Ali. Professor Tahir Masood is Professor Emeritus, Children's Hospital Lahore, and is a member of DIAG. Professor Muhammad Ali is retired professor from SIMS and is also a member of DIAG and has contributed a lot to it. A very warm welcome to both of our respected professors and teachers, and profound gratitude for their time and expertise. Our speakers for today will be Dr. Navira Arshad, Senior Registrar Pediatrics, King Edward Medical University, Professor Muhammad Fahim Afzal, and Professor Muhammad Harun Hamid, Chairman and Head of Pediatric Department, New Hospital, Lahore. Before we start our formal proceedings for our today's webinar, I will just take 1 minute of you, and we will start with Dua Maghfirat for Dr. Maria Saeed. If all of you can kindly recite Surah Fatiha for her for just 1 minute. Thank you, everyone. And just to start off, I will request everyone again to please keep their microphones muted, and you can close your videos also. We'll ask everyone to open up their videos in the end for a group photo. Thank you so much. I will request Dr. Navera Arshad to start her lecture.
Assalamu alaikum. Am I audible?
Yes,
Assalamu
Navera.
alaikum. Yes. Assalamu alaikum. I am Dr. Bismillah Rahman Rahim. I am Dr. Navera Arshad, Senior Registrar Pediatric Medicine Unit 1 from New Hospital Lahore. And today I will be discussing epidemiology and pathogenesis of dengue infection in view of surge of patient, especially surge of dengue infection, especially in Lahore, Punjab. So starting with epidemiology, dengue has emerged as one of the most important mosquito-borne viral disease of the year and carries significant morbidity and mortality. It is basically predominantly a disease of urban and semi-urban areas in the tropics and subtropics. Then why the global spread? The global spread of the disease owes credit to mass transportation and warfare. World Health Organization estimates the burden of disease in 2018 that around 390 million dengue infections occur each year, and out of which 96 million are clinical. As we see in this world map, these all areas are showing the presence of dengue infection, and Pakistan comes here in the medium area. So, dengue has emerged in Pakistan over the last decade and has unfolded into an epidemic. Previously, there are also multiple sporadic cases are reported, but in 2011, around 22,000 cases with 350 deaths pushed the public health into the limelight, thus attracting international and national expertise and development of a novel prevention and control program. Punjab has seen the disease for a decade now and will be passing on to the hyperendemicity by another 15 to 20 years. Important point regarding the pediatric population here is a major shift over this period will be that the disease and the more severe disease like DHF will be more rampant in the younger age group rather than the middle age group. With we see the data shows the peak of the dengue fever in Punjab. The data shows that it peaks around mid-July to mid-November area, mid-November months of the year, with minor drift owing to the rainfall and drop in temperature. As we all know that in these months we have cooling down and low temperature, and these all leads to more dengue infection in children. So, why dengue infection? How dengue infection is occurred? Dengue infection is caused by dengue virus, which is a mosquito-borne flavivirus, and it is transmitted by Aedes aegyptis and Aedes albopicus, as we are seeing here. And these are the white spots on these mosquitoes. There are five distinct serotypes are recognized: one, two, three, four, and five. Important point is this is that each episode of infection induce a lifelong protective immunity to that serotype only, but confers only partial and transient protection against the subsequent infection by the other serotype. This then it carry the virus in itself. When this mosquito bites a healthy person, it transmits this virus to this healthy person, and ultimately this person comes down with the dengue fever. Regarding the life cycle of flavivirus first of all attach to the cell's surface, and then it enters into the cytoplasm, and here virus fuse and produce multiple proteins, and when after that it replicates the RNA and new virus forms, and these new virions when mature cell membrane cleaves down, and all of these release into the bloodstream and ultimately leads to clinical prodrome of disease. And bone marrow blood increase usually between 3 to 10 days. Viremia is detectable in humans 6 to 18 hours before the onset of symptom and ends as the fever resolves. Both innate and adaptive immunity responses play an important role in clearance of infection. Why breakbone symptoms occur? Breakbone symptoms occur due to adventitial and dendritic cell involvement of the marrow, and similarly cytopenia occur due to a direct bone marrow involvement. This is the picture showing the pathogenesis of the disease. Infecting virus reacts with the antibody, and when these two bind together, they form viral antibody complexes. This viral antibody complex attach to the cell bearing receptor for the Fc portion of the antibody. It means that all the cell which carry the Fc portion of the antibody on their cell surface, they all bind to this complex. Then this facilitate entry of the virus into these cells and the viral replication occur. Therefore, more cells are infected, leads to increased immune response, more release of cytokines, and ultimately leads to the disease clinical symptoms. With subsequent viral infection, first infection when patient exposed to second serotype, these cross-reactive T cells causes activation of the more T cells. These T cells are less effective in eliminating the secondary infecting dengue virus, but these T cell leads to more severe disease because they lead to more increased production of the cytokines. This is the picture which is showing the pathogenesis of the plasma leakage phase of dengue hemorrhagic fever. So what happened is dengue virus specific antibody interact with endothelium, and these dengue virus infect with endothelium and kills these cells along with the increased cytokine production from macrophages, endothelial cells, and activated T cells. All these causes exaggerated cytokine response, and all this causes endothelial dysfunction. Kindly keep in mind endothelial injury is not occurred in dengue syndrome, but endothelial dysfunction occurred due to exaggerated cytokine response and endothelial
वैसे
why
डाल देती होती है
thrombocytopenia
3 बना दे इकट्ठे
why
थैंक यू
thrombocytopenia occurred in dengue fever? There are multiple There are multiple reasons due to direct viral bone marrow suppression of the disease. Of direct virus directly causes the bone marrow suppression, maybe due to increased consumption, as in case of disseminated intravascular coagulation. Direct infection of the platelet with the virus directly kill the platelets, or increased destruction of the platelets by the activated macrophages. Similarly, why bleeding occur in dengue fever? Maybe of course due to thrombocytopenia, due to increased consumption, disseminated intravascular coagulation, or in cases of poor perfusion of GLT can lead to mucosal damage. And in some patients self-medicate themselves and use NSAIDs that also contribute to the bleeding in these type of patients. Organ involvement occur either due to direct organ involvement by infecting the hepatocytes and causes the necrosis of the hepatocytes or brain with the dengue fever, or the patient with circulatory failure like in patients with dengue shock syndrome due to poor organ perfusion, the helps in causes the organ involvement in these patients. And last but not the least, like in any other virus, many organ involvement has been reported, like myositis, pancreatitis, myocarditis, GB syndrome, Steven Johnson syndrome. Feature may vary from one year to another, and one abnormal. This sums up my presentation. Thank you.
Thank you, Dr. Navera. For next presentation, I would like to invite Professor Muhammad Fahim Afzal, who is Professor of Pediatrics in PGMI, Lahore General Hospital.
Thank you very much, Dr. Shafaq. I am audible to everyone now.
Yes, sir.
Assalamu alaikum. Okay, and my screen is being shared. Screen is
Ji,
visible.
sir. Ji, sir.
Okay. Okay. Thank you very much. Uh, After the brief introduction from the epidemiology and pathogenesis, I would just walk through the case definitions and a brief about laboratory diagnosis. We are living in the epidemic area, and in 2011, WHO has given a few case definitions. Later on, dengue expert advisory group have modified these definitions according to the local circumstances. So I would be briefly talking about both of the definitions so that we must be clear that what definitions are given by the WHO and what definition actually we have to use during our day-to-day practice while living in the Punjab following the dengue expert advisory group and government of the Punjab. Now, what the WHO says that if acute febrile illness for 2 to 7 days with two or more of the following symptoms like headache, body aches, retroorbital pain, myalgia, arthralgia, rash, hemorrhagic manifestations, and leukopenia, WBC less than 5,000, and thrombocytopenia, platelets less than 1,50,000, and the rising hematocrit is 5 to 10%. Remember that if we are not taking much and intake is low, our hematocrit usually rises to this much extent. So 5 to 10% doesn't mean that the patient is in a leaky phase. And if all these manifestations case is confirmed by some laboratory criteria, which we will talk later, the case would be labeled as confirmed case. And what would be the dengue hemorrhagic fever? For the dengue hemorrhagic fever, four things must be present. One is the history of fever, which lasts 2 to 7 days. Usually, fever is there, but occasionally it's biphasic fever. There might be hemorrhagic tendencies, evidences by at least one of the following: in positive tourniquet test, and we all know by our experience from the epidemics. The Polsnicki test is done by inflating the blood pressure between systolic and diastolic, and we maintain the BP cuff in that range for few minutes. And 1 square inch area, we measure the pechi. If you allow me, I can, okay, if the time allows, I would be showing the video for the tourniquet test as well. If there are petechiae 10 or more in that 1 square inch area, then we would be labeling as positive tourniquet test. Along with the positive tourniquet test, petechiae, ecchymosis or purpura, bleeding from mucosa, gastrointestinal tract bleed, injection site bleed or bleed from any other location will be considered as hemorrhagic tendency. There would be thrombocytopenia less than 100,000 cells per square millimeter. And the most important in this is evidence of plasma leakage. The evidence of plasma leakage would be found as the rise in hematocrit equal to or greater than 20% above the average for age, sex, and population. If there is pleural effusion, ascites, hypoproteinemia or hypocholesterolemia, or even if there is pericholecystic edema, that would be taken as evidence of plasma leakage. So the four things: fever, evidence of hemorrhagic manifestation, thrombocytopenia, and plasma leakage, these four things make the diagnosis of dengue hemorrhagic fever. It is actually the misnomer, we can say that it is the hemorrhagic manifestation may occur in dengue fever, it is actually the dengue leaky fever, we can say for our remembrance, but for the terminology, we would say it as dengue hemorrhagic fever. So, by walking through these two case definitions given by the WHO, then WHO further classified these cases into different stages. Dengue fever is simple to classify. I will not need to repeat all this. This is the criteria for the dengue fever. And what the dengue hemorrhagic fever is further bifurcated is the stage 1 is fever and hemorrhagic manifestation. In this dengue hemorrhagic fever stage 1, there would be no spontaneous bleeding. There would be fever, there would be hemorrhagic manifestations, there would be thrombocytopenia and evidence of plasma leakage, but there would be no obvious spontaneous bleed. If there is spontaneous bleed alongside of all the four criteria fulfilling the case definition of DHF, that would be labeled as DHF2. These 1 and 2 categories are labeled as dengue hemorrhagic fever non-shock categories. And if we come down, all these four criteria of fever, hemorrhagic manifestation, thrombocytopenia, and evidence of plasma leakage fulfilling the clinical case definition of DHF alongside of weak pulse or narrow pulse pressure, and the narrow pulse pressure is the difference between the systolic and diastolic blood pressure, which is there is less than 20 or 25 millimeter of mercury, that would be labeled as narrow pulse pressure, or there would be hypotension. This is the stage, this is the grade which is labeled as DHF grade 3, and this is the grade which we must be having alert that this is the compensated shock, or shock is going to be started. So from here, this grading of shock start, the DHF grade 3 is compensated shock. And what the grade 4 is, if all these criteria are being met with profound shock, undetectable blood pressure and pulse pressure, that would be labeled as DHF grade 4. These categories are, or these grading is being done to avoid the terminology of dengue shock syndrome, because that was quite confusing that grade 3 was shock, 4 was shock. So DHF 3 is compensated shock and DHF 4 is decompensated shock. So these are the guidelines given by the WHO. Now, what the local experts from Dengue Advisory Group Punjab and Government of Punjab says that for all the reporting purposes, for all the inclusion purposes, we should follow these guidelines. हमें ये पता है कि जब भी आउटब्रेक होती है, आपको भी अगर आप टाइफाइड की आउटब्रेक को भी जो रिसेंट आउटब्रेक हुई या कोविड की आउटब्रेक को देखें, उसको अगर जहन में लाएं, तो किसी भी आउटब्रेक सिचुएशन में सबसे पहले हम क्या करते हैं, हम उसकी सर्विलेंस की तरफ जाते हैं। और सर्विलेंस के लिए हमें क्या चाहिए, हमें एक ऐसी केस डेफिनेशन चाहिए जिसपे कि हम केसेस को सस्पेक्ट कर सकें, बहुत सारे केसेस मिस ना हो। सो ऑन दिस बेसिस डेंगू एक्सपर्ट एडवाइजरी ग्रुप ने उस वक्त की डेफिनेशन बनाई, इफ देयर इज फीवर फॉर मोर देन 2 days और लेस देन 10 days, इस ब्रैकेट के फीवर में जो भी को आएगा उसके एसोसिएटेड सिम्टम्स को देखें। If there is headache, retroorbital pain, myalgia, arthalgia, severe backache, bone pain, irritability in infants, rash, bleeding manifestations, severe abdominal pain, decreased urinary output despite adequate fluid intake, इस ब्रैकेट में कोई भी आता है, if there is fever and any two of the symptoms described just now, you should suspect the case. और जिसको आप सस्पेक्ट करेंगे आप उसी का ही सीबीसी करवाएंगे। आप सिंपल सीबीसी और बाइसाइटोपिनिया की रिपोर्ट जो पेशेंट लेके आता है उस बेस पे आप डेंगू को डिक्लेयर नहीं करेंगे. So the patient whom we are suspecting the dengue fever, we would be going for further investigation of CBC and platelet. If there is less than 4,000 WBC, less than 100,000 platelet, or for any following trend of these platelet or hematocrit rise हो रहा है या there is a major fall in hematocrit, वो इस मैनेजमेंट में बात होगी कि मेजर फॉल क्यों आता है. For these purpose, if there is rising hematocrit or any other warning sign, तो उस पेशेंट को we would be declaring as probable case. और जिसको हम probable case declare करेंगे उसको ही हम confirmatory investigation की तरफ लेके जाएंगे. और confirmatory investigation की हम just अभी बात करते हैं. So for all the practical purposes, while working in our units, while reporting to the higher authorities, we would be following this dengue expert advisory group criteria and these case definition to declare the patient as suspected case, followed by probable case and then confirmed case. यहीं पे बात करते चलूं कि जिसको आप probable कहेंगे, preferably उसको आप admit करें, उसको रिपोर्ट करें और उसको आप फर्दर इन्वेस्टिगेट करें ताकि उसके क्रिटिकल फेज को मिस ना कर सकें. अब हम कुछ ब्रीफली बात करते हैं फेजेस ऑफ डेंगू इन्फेक्शन. फेब्राइल फेज, क्रिटिकल फेज एंड रिकवरी और कन्वालेसेंट फेज. Usually dengue fever has no critical phase. Febrile phase lasts for 2 to 7 days and convalescent phase usually lasts for 2 to 5 days. While in dengue hemorrhagic fever, its febrile phase is followed by the critical phase that may start from the day 3 or day 4 and then last for 44 to 48 hours. This is followed by the convalescent phase and the management of critical phase is the most important part. If we talk about the investigation, किसी भी infectious diseases की हम investigation में हमें उसका culture required होता है, हमें उसका PCR चाहिए होता है, हमें उसके antigen या antibodies required होती हैं. तो यही 4 चीज़ें dengue infection के diagnosis के लिए भी required हैं. These are the confirmatory investigations and these are the ancillary investigation which are required to make the diagnosis to fulfill the case definitions. Now, first we talk about the confirmatory investigations. As talked earlier by the previous speaker, that is phase of viremia. And the phase of viremia is 2 days prior and 5 days after the onset of the fever. This is whole phase of viremia. In phase of viremia, we can have the non-structured protein 1, which is abbreviated as NS1. We can have virus isolation. We can have RNA detection by PCR, and we can have the genetic testing and further sequencing. After 7 days, after usually 5 or 6 days, there is no utility of these 3 tests as NS1, virus isolation, or RNA detection. After that, we would be going to serology, which is IgM and IgG. By seeing this graph, you can well observe that
ये रख के आओ, उधर रख के आओ, पापा जी की तरफ में जाओ.
primary infection, IgM appears. Am I audible now, Dr. Shafaq?
Ji, sir, you are.
Okay, the mic was unmuted. Okay. IgM appears earlier, takes a peak, and then falls down. But in primary infection, IgG appears a bit late. While if we have to diagnose the acute infection in case on the serology, we would have to have IgM and IgG, and we would be going for the convalescent sera to see the four-fold rise in IgG titer. Here, if you see the graph, in secondary infection, IgG is there, and they may take a peak a bit earlier. And if we go for the ratio of IgM to IgG, we can predict that this is primary infection or secondary infection. But remember that the timing of sending the sample and interpretation of laboratory result is important here. Now, in hematological parameter, we can have hemoglobin, WBC, hematocrit, and platelet. Usually WBC normal with predominant lymphocyte in early febrile phase, and there would be leukopenia later. But going back to pathophysiology, in the phase of pyremia, there are two pathophysiologies are there: bone marrow suppression and consumption coagulopathy. In bone marrow suppression, there is leukopenia, and in consumption coagulopathy and bone marrow suppression, the platelet counts are decreased. When the phase of viremia is over, there is defervescence of fever. The WBC count starts rising while the platelet are still at lower side. If we are seeing that there is big drop in platelet and there is reversal of neutral-lympho ratio, this is an important indicator of identification of critical phase. Initially hematocrit is normal, and if this take rise and 20% or more than the baseline, this is again an indication of critical phase and leaky phase. We can have ultrasound abdomen to see the ascites and pericholecystic edema. We can have chest X-ray to see the pleural effusion. We can have serum cholesterol level if this is falling, and serum albumin level if this is falling. That can predict the evidence of plasma leakage. Then depending upon the condition of the patient, if the patient is compensated or in profound shock, meaning by the if the patient is in DHF grade 3 or DHF grade 4, we can have further investigation like blood glucose, blood gas analysis, serum electrolyte, creatinine, urea, liver function, calcium. Coagulation profile is very much important in the patient who are landing with the shock, because if we have to give the dextran to these patients, dextran interferes with the agglutination, and if we have given the patient the dextran, we would be in trouble to get the blood grouping and cross matching. So blood grouping and cross matching is another important test which should be done right at the start if we receive the patient with a shock. Cardiac enzyme and ECG if indicated, and serum amylase and other investigation as indicated individually. Now, after the laboratory investigation, just I would take a pause to familiarize you with the reporting form. This is the form which is being used in outdoor O form, and O is for orange color. This is for the reporting purposes in outdoor cases patient, the patient to whom you suspect the case and declare the probable, you admit and you just report to the authorities. And this is the arm form, which is made as in red color. This arm form is used to report for the inpatients with the name and signature of the registrar, senior registrar, and your administrative and clinical focal person. And this information is updated on PITB dashboard. This is a standardized dengue counter design which is recommended by the DAG and Government of Punjab. When the patient enters in the fever area or fever counter, there should be first nursing counter which record the vitals, take the CBC, and this is analysis of the CBC after taking the vitals, and then reviewing of the laboratory tests by the doctor in charge of the counter and filling the form, reporting to the PITB, and decision made if the patient has to be discharged or has to be admitted in indoor facility. So this is the brief about the dengue counter design, and thank you very much. I would hand over the mic to Dr. Shafaq for further proceeding.
Thank you so much, sir. We'll quickly move to the management part of dengue infection, which is by Professor Muhammad Harun Hamid. He is Professor and Head of Pediatric Department, King Edward Medical University. Sir, you are not audible to us.
जी अब आवाज आ रही है आप लोगों को?
जी सर अब आ रही है. Now we can hear you.
जी बिस्मिल्लाहिर्रहमानिर्रहीम. Thank you very much. सबसे पहले तो I would like to pay my gratitude to my teachers who are joining us as the panel of experts, Professor Tahir Masood Ahmed Saab and Professor Muhammad Ali Khan Saab. Just to apprise everybody that when the big epidemic came in Lahore in 2011, Professor Tahir Saab was heading Children's Hospital, now the University of Child Health, as dean, and he actually led the whole the fight, I would say, against dengue fever. And Professor Muhammad Ali Saab, he has been the founder member of DAC, along with Professor Faisal Masood Saab Marhoom. And Professor Muhammad Ali Saab has played a very vital role in organizing all these guidelines and making these forms along with the other members of DAC. So, sir, I am honored to have you, both of you, as our panel of experts. Dr. Navera and Dr. Fahim has made my task a little easier, having talked about the epidemiology and the pathophysiology of dengue and dengue hemorrhagic fever, and the case definitions by Dr. Fahim was very, very helpful. I think one of the very important things that we are going to discuss today in next 30-35 minutes is how to differentiate between not so troublesome dengue fever to the troublesome dengue hemorrhagic fever. And we're going to talk about the management of dengue fever, how to monitor the patients during both of these diseases, the dengue fever and the dengue hemorrhagic fever. And of course, a little bit about the management of dengue hemorrhagic fever or dengue leak fever, if you want to call it like that. So this is very important for us as clinicians to differentiate between dengue fever and dengue hemorrhagic fever, as has been highlighted by Dr. Fahim, and I'm not going to go into the details, but I want to say here that all those patients who suffer from dengue viral infection, they do not manifest the clinical features. As a matter of fact, in a naive population, 90% would be asymptomatic, and ours perhaps may not be a naive population. Our asymptomatic population may not be 90%, but still it would be a vast majority of the patients having infection but not manifesting any symptoms whatsoever. The implications of this understanding. So if you are seeing one patient of a symptomatic dengue infection with the symptoms of fever, headache, retroorbital pain, and all those symptoms which Dr. Fahim has described, it means that against that one patient, you have 9 more patients in the community who are carrying the virus, and mosquito, if it does bite that person, is going to transmit the virus from that asymptomatic patient to the other patients who may become symptomatic, and some of them may have the troublesome form of dengue infection as well. So those who does manifest symptomatic dengue fever do have these symptoms, about half of them would have non-specific viral prodromes. 4% of this 10%, that is about 40% of the symptomatic ones, would have the classical features which Dr. Fahim described: high fever, headache, retroorbital pain, myalgias, arthralgias, vomiting, abdominal pain, diarrhea, loss of appetite, and sometimes bleeding manifestations. Remember, the bleeding manifestations may be present in the dengue fever as well. Hence, all those patients with bleeding are not necessarily dengue hemorrhagic fever. Dengue hemorrhagic fevers would be the one who have plasma leakage, that has already been said. And a very small subset would have what we call unusual or expanded dengue syndrome, which are very less. So we really don't have to worry about this bit, but we need to realize that symptomatic are not the commonest patients with the infection, and those who do have symptoms, all of them do not end up having plasma leakage, and all of them do not fall in the category of dengue hemorrhagic fever, even if they do have some manifestations of bleeding. Please mic mute kar lijiye baki log. And as has been said earlier, so dengue hemorrhagic fever and dengue shock syndrome is perhaps a continuum if not taken care of. They've been covered absolutely fantastic. Just to quickly revise, that presence of 2 or more clinical features in a region or a season, you suspect them to have dengue fever. You have supportive lab evidence as low WBCs and low platelets, you label them as probable cases of dengue fever, and you have a confirmatory test, either NS1 antigen or serology, you label them as confirmed dengue fever. Important to differentiate between the dengue fever and dengue hemorrhagic fever, because the management may be a little different, the monitoring may be a little different, and the most important thing, the fluid management would be entirely different in dengue fever from dengue hemorrhagic fever. The last thing that I want to say over here in this slide is that remember what is written over there. Dengue hemorrhagic fever is not a complicated form of dengue fever. It is a separate disease in itself. So some of the patients who have dengue infection would end up actually having dengue hemorrhagic fever, but we would not know in the initial febrile phase if it is dengue fever or dengue hemorrhagic fever. But then by the clinical and the other laboratory parameters, we need to differentiate so that we can manage them appropriately. Coming to the management part, so those who have these classical signs of fever and myalgias and so on and so forth, but they are not in the time period where you would do CBC to look for neutropenia or thrombocytopenia. These are the suspected cases. They need not be admitted in the hospital. You can send them home, make sure that they are taking adequate fluids, paracetamol for pain and fever, paracetamol for pain and fever, and no NSAIDs, no aspirin, brufen, of course, no role of steroids whatsoever. And then to categorize them as probable, you would do a CBC on day 3 or later. You can do CBC earlier if clinical features suggest that there might be something else happening. If you have, for example, a suspicion of co-infection with, say, enteric fever or whatever. So for a classical case, CBC on day 3 or later. But not only that, they can go home, but they need to be seen and followed up daily. And on daily basis, we need to look for the danger signs or any clinical features that suggest that they are deteriorating. And then we need to look at the trends of the CBC, the white cells, the platelets, and the hematocrits from day 3 onwards. And we need to make sure that they know when to return to hospital immediately. If they are not able to tolerate orally at all, they are throwing up everything. A small infant is refusing to eat or drink. Extreme thirst can be a manifestation that the patient might be in what we call the leak phase. So we need to be careful about these patients, those with severe abdominal pain, mucosal bleeding, not passing urine, perhaps lack of intravascular volume because of leaking or because of dehydration. Behavior changes, being a manifestation of the dengue infection itself, very less likely, but more likely to be manifestation of poor perfusion, dehydration, confusion, irritability. So they need to report to hospital immediately if they have behavior changes. Last but not the least, but very important for us to understand as physician is that sometimes, well, not sometimes, but most of the time, the cases of dengue hemorrhagic fever, when their fever settles and they become unwell, their vomiting worsens, their abdominal pain worsens, or they have mucosal bleeding, or their appetite is decreased further, that might be an indication of the fact that they are in the critical leakage phase. So we need to make sure that don't be reassured that the fever is settled and rest would be all right. If fever is settled, but clinically they are unwell, this might be an indicator of something sinister going on. So we need to give them this handout written in Urdu, made by DI, Professor Muhammad Ali Saab and others. So we need to give them this handout for those who can read and for those who can understand. Or what they need to come and report. So when do we admit them? As of now, the consensus is to admit all probable cases of dengue so that we can detect if any of them is going into the critical or leakage phase. So we need to detect that critical moment, and that can happen only if they are admitted in the hospital. So admit all probable cases. And just to revise for everybody, our probable cases is with the classical features, with the white count less than 4,000 and the platelet count less than 100,000, admit probable cases. Suspected cases, not falling in the category of probable cases, but have warning signs, like I have been I talked about in the previous slide. So you need to admit them if they have got warning sign. One important sign that I want to highlight over here is tender hepatomegaly. If they have got tender hepatomegaly, that is a very strong indicator of them going into the critical leakage phase. So we need to look for that very closely. Of course, a rapid fall in the platelet count. And for pediatricians, this is important for the pediatricians, small infants, because of their intricacies with the fluid balance and their ability to take enough milk or feed. So we need to admit all infants less than 6 months, those who have got comorbid conditions, diabetes, congenital heart diseases, chronic kidney diseases, poorly controlled asthma, bleeding diatheses, hemolytic diseases, malignancies on cytotoxic drugs. You need to admit them. Obese patients, because the fluid management in these would be very, very tricky. So it would be wise to keep them in the hospital. Now, this last bit is very, very important that I don't know have gone out of the current guidelines, but those who live away from their parents, students, teenagers living in the hostels and are not being taken care of by their parents or the guardians, better to keep them in the hospital, even if they are not in the probable category, living away from their home, or unreliable parents. And I always crack a joke when we talk about unreliable parents, so I will just leave it here. So when you have admitted these patients based on these admission criteria, what do you do? So the probable cases are admitted, and these probable cases who are admitted may be cases of dengue fever or maybe cases of dengue hemorrhagic fever. So we need to put them under the nets during the febrile phase only. And I will stop here about the nets. So during the febrile phase, we need to treat them with a similar management plan. May it be a case of dengue fever or dengue hemorrhagic fever, because in the febrile phase we do not know if it is DF or DHF. We need to monitor them closely. We need to make sure that their fluid balance is all right, and we need to try to recognize their critical leakage phase earlier by the methods that I'm going to share with you shortly, and the lab test that Dr. Fahim has already talked about. And if everything remains all right, of course, then they can go home. And we're going to talk briefly about the discharge criteria as well. So in the febrile phase, fluid balance is very, very important. If they are not able to take orally or tolerate orally, and they are vomiting everything, so you need to give them the maintenance fluid, just the normal maintenance fluid. Remember here, I emphasize, during the febrile phase, just the normal maintenance fluids. And if they are dehydrated because of persistent vomiting, that degree of deficit along with the maintenance fluid. So if they are not dehydrated, but they are not taking enough, so you admit them and you give them just the normal maintenance fluids. For example, a 10 kilogram old infant, 100 ml per kg in 24 hours, febrile phase. Repeat that, febrile phase. However, as the day of illness of fever approaches day 3 onwards, day 4, 5, we need to be cautious about the amount of fluid they are being given intravenously. Because if it is a case of dengue hemorrhagic fever, they are going to go into the leakage phase at this point in time, day 4, day 5. And if you are giving them a lot of intravenous fluids, all the fluid that you are going to give them in the veins is going to go out of the veins into the third species, the peritoneal cavity and the pleural cavity, and that is going to worsen the situation. So cautious fluid after day 3. Of course, they would be bed rest. They won't be able to move it because of this. No NSAIDs, as we talked earlier. Monitoring during the febrile phase using the chart A, which I'm going to show you, and I'm sure it is present in all the hospital, in all the pediatric departments, using the chart A just to monitor the vital signs. Remember, there is no hi-fi monitoring of these patients. Just the temperature record, the pulse, the respiratory rate, the blood pressure, the capillary refill time, and you do that every 4 hours. And you need to make sure that you have an accurate record of what goes in and what goes out. And you need to do a CBC to look at the trends of WBC, platelets, and the hematocrit once or twice daily. Because as Dr. Fahim has already mentioned, that as the critical leakage phase arrives, their platelets are going to fall down really rapidly. There might be change in the neutrophil lymphocyte ratio, and hematocrit would tend to increase because the intravascular volume is being depleted. So we need to monitor that. And of course, you can monitor hematocrit bedside. And if you have got facility of monitoring hematocrit at bedside, you can do it more often. So this is the chart which we use for monitoring of patients during the febrile phase. So you can see that this is the time over here, 4 hours, every 4 hours. The time, the temperature, the heart rate, the blood pressure, BP, pulse, and capillary refill time, hands are warm or cold, any bleeding diathesis, if they vomit a lot, and the amount of fluid that goes in orally or IV, and the urine output they are passing, the WBC count and the platelet count, the hematocrit, and if you decide to do an ultrasound on day 4 or day 5, based on your clinical parameters, that this is likely to have leaking because of falling in the platelets and the worsening of the condition, you need to document all that in this monitoring chart. And just by looking at this monitoring chart, you can predict if they are going into the leakage phase or not. Quickly, I think I would try to make it as quick as possible. Now, this is an example of a 7-year-old child, 26 kilogram, as a sort of a hypothetical chart. And you can see that the heart rate has been stable, 80, 84, and it actually has improving over here, as is the blood pressure. And if you look at the platelet count, they start falling, they fall over here, and then just they start rising. And as the platelets start rising, you can see that their temperature settles and their clinical condition improves. Their appetite returns. They may have this peculiar rash, the recovery rash. And if that happens, this means that the child is out of the febrile phase and is into the convalescent phase, because they do not have those signs of leakage. And you label that patient as a patient of dengue fever. The natural course of dengue fever, as has been highlighted, is the recovery after a period of febrile phase. They do not have this critical phase. Now, in contrast, look at the case over here. Now you see that in this case, in this particular case, I can tell you that as the fever settled around day 3 over here of the admission, day 5 of the fever and day 3 of the admission, you can see that there is a rapid fall in the platelet count here. And the hematocrit has jumped up a little bit. And the clinical condition worsens, although the fever decreases, but there is more vomiting, more abdominal pain. So this suggests that the patient is going into the leaking phase. So to confirm the leakage, what you need to do is, based on these parameters, you need to confirm it by doing an ultrasound and to document that there is leak and how much leak there is, right? So this is what the natural course of dengue hemorrhagic fever would be, that they would have a leaking phase. The good thing about this leakage phase is that this is not a relentless phase. It would not last for ages. It generally would last for 24, max 48 hours. Very important again. We talked about the time of the fever, and so that we can time the possibility when the leakage would occur. We also want to time the start of the leakage phase, because we know that the leakage phase is going to end in 48 hours, so that we can change our fluid management strategy accordingly. So a good news about that, you need to closely monitor them only for 48 hours if everything else is all right. So this is the way we can detect a leakage critical phase earlier, as I said earlier, a rapid fall in the platelet count, plus if they are rising the hematocrit, of course, progressively rising hematocrit despite adequate fluids, and evidence of plasma leakage if you have objective evidence in the form of ultrasound or chest x-ray. In doubtful cases, one might consider doing an albumin or cholesterol, but I want to say that this is something that should be reserved for very doubtful cases. It is not needed as a routine. I think this has been covered in the previous slide as well. So how do we manage a child whom we admitted as a probable case, and on day 4, day 5, as the fever settles, the platelet fell down, and the clinical condition showed little deterioration, that there is more tachycardia, there is more prolonged capillary fill time, and the ultrasound does show that there is evidence of leakage. So now this child is in the critical phase. So what do we need to do with this child? Only 2 things that we need to do. We need to just monitor this child carefully, very closely, 1 hourly at least, and we need to make sure that we are giving them fluid according to what we call the fluid quota. So as far as monitoring is concerned, remember, although the leakage phase would last for 48 hours, this is not something that would take a pattern. Generally, a graph is shown in the books which shows a pattern, a rising and the falling. This is not like that. Remember, the leaking phase is a dynamic phase. Although the leaking would start and would peak and would come down, but it may not follow a smooth trend. It may be zigzag. It's a dynamic phase. The leak may be more during first hour, or more during hour 6, or more during hour 12, so on and so forth. So you need to monitor them 1 hourly, so that you can see how much leak is occurring each hour, so that you can give them fluids accordingly. Also, it is important to not only give them fluids to prevent them from going into what we used to say dengue shock syndrome. And if they are in dengue shock syndrome, to prevent them into going into what we call a decompensated dengue shock syndrome. We talked about the onset and the duration, and the monitoring chart, we follow the chart B. I'm going to show you that. The parameters that we see, not a single reading is important. The trends are important of the pulse, the blood pressure, the pulse pressure, the capillary refill time, the respiratory rate, intake output record, extremities if they are warm or cold, the amount of fluid that goes in. If they have got any bleeding, this is very important, and I'm going to touch upon that, any obvious or any hidden bleeding. And we need to then do their hematocrit 4 to 6 hourly. Remember, we said that we are going to monitor their platelets and the hematocrit maybe once or twice during the febrile phase. In the critical phase, you might want to do it more often, maybe every 6 hours, depending upon the condition of the patient. And if you are doing the bedside, you can do it every 4 hours, no problem at all. And the frequency of monitoring, in grade 1 and grade 2, at least 1 hourly monitoring should be done. And if they are in what we used to say dengue shock syndrome, then depending upon their condition, every 15 to 30 minutes, you need to monitor their vital signs and all these parameters. And this is a chart that we use. I will show you a close-up of this chart. Now, this chart, the upper part is showing the fluid that are going in per minute. So the amount of the rate of fluid that is going per minute, 1 ml per kg per hour, or so on and so forth. And the bottom bit actually gives you the vital signs and the lab parameters. So by looking at this chart holistically over time, you can see what is happening with your fluid balance in and out, and you can fine tune their fluid accordingly, and you can prevent them from going into the shock, or preventing from them going into what we call decompensated shock. The important thing to remember, which I'm going to talk again, is Dr. Rahman, can you please keep your video closed? Thank you, Dr. Rahman. So how to time the onset? So just to give you an example, how to time the onset, just the WBC count and the platelet count. Look at the platelet count over here. So they started falling down, sudden fall from day 4 to day 5, from 10,000 to 61,000. So this is a big fall. So this big fall suggests that something is happening over here. So perhaps this is the onset of the critical phase. And if you look at the hematocrit closely, you can see that the hematocrit is rising over here, right? And there is a change in the white count as well. So these two bits, the hematocrit and platelets, are going to give you an indication that that perhaps the critical phase has set in, and you do an ultrasound and document that the critical phase has set in. And as you go along, you see that the platelets are further decreasing, and they are further decreasing, and they are further decreasing, and they are further decreasing, and then they start improving, right? So here the critical phase ends around here when the platelet count start increasing. This is the way you would do a bedside hematocrit. I love it, but unfortunately, I don't know what is the reason. I think we are going to discuss that. We need to arrange these bedside monitoring devices, which are very easy to use. Now, other than the monitoring, the other thing that we talked about doing in the critical phase is the fluid management. Now, remember, just to recap, in the febrile phase, we just gave the normal maintenance fluids, and if they were dehydrated, we will hydrate them. But here we need to be very, very cautious, because whatever amount of fluid you give them is likely to leak out from the capillaries into the third spacing, worsening the condition, worsening the ascites or the pleural effusion. So we need to make sure that the amount of volume that they get, do not over transfuse them and overhydrate them. And of course, if we do not give them fluid, they may end up having poor intravascular volume and dehydration. So we need to be very careful about the fluid balance, giving them just the enough fluid. And that would happen with the meticulous monitoring of the vital signs and the input-output record. The fluid, just the normal saline, normal saline, normal saline. And if there are chances that the child might have hypoglycemia, for example, a malnourished child or a very small young child, you might consider adding dextrose to them. In infants less than 6 months, it's half saline, although there are certain studies which suggest that even in infants beyond the neonatal age, you may continue giving normal saline. But I think this is for our panel of experts to address. So the other thing that I'm sure that all of you are aware of, just I want to highlight and emphasize, is the fluid quota during the critical phase. What does it mean? It means that we calculate the maintenance fluid of that particular child for 24 hours, maintenance fluid for 24 hours, and we add a deficit of 5% to that maintenance fluid, because we expect that up to 5% of the plasma is going to leak, if it is going to leak a lot, generally speaking. So the 5% deficit plus the maintenance for 24 hours constitute the fluid quota of that child. But this fluid quota is to be given over 48 hours. Over 48 hours. And a caution over here. This does not mean that all of this fluid quota has to be given over 48 hours. This means that this is the maximum fluid that you can give in 48 hours. Many a times you would end up giving less than the fluid quota. And that I'm going to talk about how do you do that, right? The other thing, very important thing, is that when you calculate their maintenance fluid, you calculate either with their ideal body weight or actual body weight, whichever is less. So for example, for a 1-year-old child, we know that the ideal body weight would be around 10 kilograms. So if the weight of that particular 1-year-old infant is 8 kilograms, you would calculate using 8 kilograms, not the ideal body weight. But if the weight of that 1-year-old infant is, say, 12 kilograms, you are not going to use 12 kilograms, you are going to use the ideal body weight. You understand that? So ideal or the actual, whichever is the less, because we don't want to give them a lot of fluid, we just want to give them enough fluids. Now, this is a chart which is present in all the books, all the guidelines. So it does not follow this smooth pattern like I was saying earlier. It would be zigzag. There might be big leak over here, and there might be big low leak over here. But generally, after 24 hours, the rate of leak would tend to decrease. But again, this would be dynamic. This would be going zigzag like that. And this you need to monitor by your vital signs and intake output record. And how do you monitor that? By not only the vital signs, but the urine output, a very objective parameter. Of course, heart rate, pulse pressure, extremities are going to give you very good clues. But if I want to say one objective parameter, I would say in a standard patient would be a urine output. So we need to maintain a urine output of between 0.5 to 1 ml per kg per hour. No less, no more. I repeat that, no less, no more. So if a child during the critical phase, I'm talking about the critical phase, is having a urine output of more than 1 ml per kg per hour, it would suggest that perhaps the child is getting more fluids. So we need to cut down our rate of fluid intake, right? So if the child is very, very unwell, suppose the child has come a little late and is already in grade 3, is in a compensated shock, you may want to start at a higher rate. And I'm going to talk about the rates a little later. But as the urine output and the vital signs change, you need to adjust the fluid rate as soon as is possible. You might want to start at 10 ml per kg per hour. If the child is in, say compensated shock, 10 ml per kg per hour. But you come down from 10 ml per kg per hour to as minimum as possible, as soon as possible. Because during the phase, whatever amount goes in the veins is going to go out of the veins into the peritoneal cavity or the pleural cavity. Right? So this rate of infusion has to be individualized depending upon the vital signs and the urine output of that particular patient. Dr. Fahim has talked about that. I'm going to skip this one. Fluid management in dengue shock syndrome, a little bit more detail about fluid management in dengue shock syndrome, or grade 3, grade 4, as we call them now. And compensated shock is where the blood pressure would be low, but would be recordable, and the pulse pressure does narrow a little bit, but would not be very, very narrow, and the urine output still would be maybe around 0.5. Even during the dengue shock syndrome, the fluid type has to be normal saline, normal saline, normal saline. Colloids like dextran 40 in normal saline in very selected cases, and I'm going to skip the indications because I don't want everybody to end up giving dextran to all the patients. So it is the normal saline for vast majority of our patients. And remember that if you have to give them fluid bolus because their pulse pressure was narrow, their blood pressure was low, that bolus would be counted towards the fluid quota. So you would not minus the fluid, the bolus from the fluid quota. So this is the chart which is available in all the wards, I guess, to manage do the fluid management of compensated and the decompensated shock. Just going to break it down a little bit. So we need to decide based on the clinical parameters and the urine output if the child has got the compensated shock or the decompensated shock. And if the child has got is in compensated shock, you give them fluid resuscitation. Now we're talking about dengue hemorrhagic fever grade 3 and 4 here, grade 3 and grade 4 here. So if it is compensated shock, you give them fluid resuscitation with normal saline 20 ml per kg over 2 hours, right? And one important thing, as we are seeing adolescent patients as well, we are seeing patients 12, 13, 14, 15 years weighing maybe more than 50 kilograms. The other thing about the use of weight for fluid calculation is that the max weight that you can use for fluid calculation is 50 kilograms, maybe adolescent child or maybe an adult. So 50 kilograms is the cutoff. So the compensated shock, you give them fluid bolus 20 ml per kg over 2 hours. For decompensated, you give them 20 ml per kg, but little fast as is possible, because this compensated shock, if it is not addressed really quickly, is going to go into what we call the profound or irreversible shock. So you need to reverse this shock really quickly. So you give them 20 ml per kg as a bolus push, and you need to send their baseline test as mentioned over here. And you see at the end of this period, 2 hours in the compensated shock and after the bolus in the decompensated shock, you see if there is any improvement or not. If there is no improvement, you repeat the hematocrit. If the hematocrit is increased or is unchanged or is less than 10 points reduction of hematocrit from the baseline, that would mean that there is a lot of ongoing fluid leaking going on. So you need to give them another fluid bolus over 1 hour of 10 ml per kg. However, if the hematocrit drop more than 10 points from the baseline, now this 10 point is very, very important. So hematocrit was say 48 when you started. You gave them a fluid bolus of 20 ml per kg. You assess the hematocrit. The hematocrit has decreased to say from 48 to, I tell you, 30. So there is a fall of 18 points from the baseline. Although we want a hematocrit fall, but we want a fall from 48 to around 38. That would be actually balancing the amount of fluid going out. If the fall is more than that, and you are sure that you have given just this amount of fluid, not more than that, then this might suggest a hidden bleed. And you need to be cautious about this patient. So you monitor them and you see if there is improvement or not. If there is improvement, you go to the other limb that I'm going to show you shortly. If there is no improvement, you check the hematocrit again, and you keep on doing that. And I'm not going to go into details of all the bits, but remember, after a boluses of 30 ml per kg, if still the child is in shock, you consider giving them the colloids, the dextran 40. But I again want to reiterate that this would not happen in vast majority of the patients. right? So I'm going to talk about what is going to happen in the vast majority of the patients is they would improve with the first bolus, most of them. And you just monitor their urine output, make sure that their urine output is between 0.5 to 1 ml per kg per hour, and you continue infusing them normal saline at a rate of 1.5 to 10 ml per kg per hour. And this rate is going to be changed every hour depending upon the vital signs and the urine output. And if there is improvement, you reduce the fluids and you monitor the hematocrit. And if your patient is unstable at any time, you go to the other side that I have shown you earlier. Now, it is important for us to recognize the critical phase so that we can see how much time do we need to give this fluid quota for, and then we can liberate giving them the fluids. We need to predict the rate of leak every hour so that the amount of fluid that goes in every hour is adjusted accordingly. And you need to be very careful about when to actually liberate your fluid regimen. So just coming towards then, I'm sorry I've taken a little longer, but I'm just going to come towards the end. The confidence whenever there is recovery, the good thing would be not only the fever would settle, but they would have good appetite. Their heart rate would come down. They may have actually relative bradycardia. There might be diuresis if they had a big leak. The hematocrit would stabilize. There would be rise in the WBC count, and there would be rise in the platelet count, and they would have this what we call a convalescent or as a recovery rash, pruritus. These are the indications that they are in the recovery phase. So what you need to do in the recovery phase, you need to make sure that they are taking enough, they have enough rest, their intake is all right. Sometimes you may end up giving them antihistamines and you do the planning for the discharge. So this is a recovery rash, what we call white island in the Red Sea. And the relative bradycardia, the sinus bradycardia, and the discharge criteria written over here. You need to make sure that they are afebrile for 24 to 48 hours. I say 24 to 48 hours, although it's written 48 hours over here. You need to make sure that there is no overt or hidden bleeding. Their vital signs are stable. They do not have respiratory distress, secondary to pleural effusion or any other reason. And they have a rising trend in the platelet count. I think I stop here. Sorry, I have taken a little longer. There are questions in the chat box, but I would let Dr. Shafaq take lead from here. And over to you, Dr. Shafaq.
Thank you so much, sir. Thank you so much for your presentation also. And yes, indeed, there are many questions in the chat box. I would request our expert panel to please involve in these answering of these questions. The first question is from Dr. Wajia Rizwan, and she has asked about the management of fluids in malnourished people, in malnourished pediatric population, especially who are of third-degree malnutrition. Professor Muhammad Ali, if you can please kindly answer this question.
Can you repeat the please question? Assalamu alaikum. I am Dr. Muhammad Ali. Can you repeat the question, please?
जी सर बिल्कुल सर डॉक्टर वजिया रिजवान ने क्वेश्चन पूछा है कि how will management of third degree malnutrition child will vary in DHF.
All right. There are a couple of points with the third degree malnourished child. Remember one thing, those patients who are immune compromised like third degree malnutrition, they are very unlikely to go into DHF because they are unable to produce cytokine storm. So, but if they do go into DHF, it is not the hard and fast rule that they will never go. But if they go, there are 2 points to be considered. Normally, in a third degree malnutrition, volume has got 2 problems. If they are very anemic due to hemodilution, there will be volume overload in the normal circumstances. And if they are mainly hypoproteinemic, and there will be contracted volume because the fluid will be already gone out to cause edema like in Kwashiorkor. So these 2 points have to be considered in mind. And even if you know that third-degree malnutrition, even with simple gastroenteritis, they are difficult to manage. They are difficult to manage. But keeping in mind DHF, the question is very valid, and it's a very difficult situation. So if they are markedly anemic, keep in mind volume overload. If they are mainly hyperproteinemic, keep in mind contracted intravascular volume. But what to do is with these children is we will follow the same rule, like Dr. Haroon has told, that we will calculate fluid to maintenance plus 5% dehydration to be given over 48 hours. If you can calculate, all of you, I will advise you just give a calculation. You will see that basically this is the maintenance, because this fluid we are giving in 2 days, 48 hours. We are calculating for 24 hours, but giving in 48 hours. You will see that this is just nothing but the maintenance fluid for 2 days. Only thing what you have to do in a patient with DHF, with malnutrition or without malnutrition, is that this fluid is given over 2 days. It is just like 2 days maintenance, but you are now, you have a allocated quota, like Dr. Haroon said, that you can give maybe half of this fluid in for 6 hours. But remaining fluid has to be given in next 24 plus 12, 36 hours. The key to in the management of DHF, that we do not know if patient is hypervolemic or patient is hypovolemic due to hypoproteinemia or due to anemia. The key to success in any patient of DHF, whether he is malnourished or not, is 1 hourly monitoring. That 1 hourly monitoring means pulse, blood pressure, you have to monitor hematocrit. That will show you the rising or the falling trend, that whether you are able to correct the volume or not. So keep it in mind that the key to success in the management of DHF, whatever the condition is, whether a normal child, whether hypoproteinemia, whether he is a malnourished child, or any patient who is having any other comorbid condition, is the monitoring. Without monitoring, no therapy can be successful. You have to monitor them every 1 hourly. That will show you whether pulse volume is improving, blood pressure is improving or not, urine volume is increasing or not, hematocrit is falling or not, and that is how you will decide fluid for the next hour. So please, whatever the condition is, always monitor them very meticulously. Every hour you have to monitor pulse, blood pressure, pulse pressure, and hematocrit and urinary output. These are very simple things. And there was another question in the chat, which I saw, maybe I will finish it here also, that how you will know that if the previous value is not available and patient has come to you, how you will assess that whether hematocrit has increased by 10 points or not. Again, the answer is same. Start your fluid according to the algorithm, and you can very easily decide in next 1 hour that what you have done, whether you have done right or wrong. But do not leave it to after 6 hours that, okay, you have started fluid and I will see it after 6 hours whether I am right or wrong. You may be right, but you can be absolutely wrong. And after that, things will be difficult to manage. I hope I have answered. If it not, please, you can ask it again. Am I audible?
Gigi, sir, you are audible. Thank you, sir. If the query is not...
Who made this question? Just I want to see a response, whether I am clear or not, whether he got the answer.
Ji, sir, let me ask her. Madam, if you can please answer it in the chat box, that if you are clear or not.
Not seeing response.
Sir, your response was very appropriate. I think, Dr. Shafaq, if we can see if there are any more questions. Thank you, sir. Professor Muhammad Ali Sahab.
Sir, then there is a similar question, was that if how to manage fluids for obese patients as well. If Sir Dr. Tahir, or if you can answer it.
Bismillahirrahmanirrahim. First of all, thank you, Haroon, for arranging this, and the PPA Punjab for arranging this very timely webinar. This was need of the time. considering the fact that dengue cases are improving. And I must express my sincere gratitude and appreciation for all the three speakers. They made the things very clear. Now, coming back to the question of obese patients, in fact, I think this was, as Haroon has already pointed out, that we would consider the optimum weight for the fluid management to be 50. We would not go beyond that. And that would take care of the obese patients as well, because irrespective of the weight of the child or weight of the patient whom we are managing, we would calculate the fluid requirement according to the maximum weight, which is 50 kilograms. So because we know that in obese individuals, the volume of extracellular volume is less compared to the people who are not obese. So that would take care of, because basically in fluid management is that we would be careful about, first of all, that we want to maintain the intravascular volume, especially in patients with the DHF or dengue leak fever. And secondly, we would not want to overload, so that during the recovery phase, when the fluid would return to the intravascular compartment, then the patient would not go into congestive heart failure. So if we stick to this optimum 50 kilogram, and if we stick to the regular fluid administration based on absolute monitoring, which Haroon has already highlighted, taking into account the urine output, and considering the fact that the leak phase may vary. It's actually the zigzag, or it may be it's very erratic. So you need to have a close monitoring of all the parameters by which you would assess the requirement of the fluids in a particular phase of the leak syndrome. So I think sticking to the basic principles, we can manage these obese patients very well. Thank you.
Thank you so much, sir. बहुत शुक्रिया, sir. Sir, there's a question from Dr. Haroon, and it has been asked that please guide about the amount of the additional fluids other than maintenance fluids per body weight, since you covered this topic for us.
Dr. Khwaja Arshad has asked this question: amount of additional fluids other than the maintenance fluid per body weight. I think I have tried to answer this question. In the febrile phase, you need to see if the child is dehydrated, and you hydrate them as you normally would hydrate any child who is dehydrated. Along with that, you would give them the normal maintenance fluid. But as we approach towards the critical phase or leakage phase, you calculate the fluid quota, and I have this is the general recommendation. You calculate the fluid quota by a 5% deficit, and you put that 5% deficit along with the maintenance of 24 hours, and this is a quota that you can give over 48 hours. There was other related question about the type of the fluid. I think Dr. Vajia asked this question. It has to be the normal saline. Normal saline is the isotonic fluid. If you give hypotonic fluid, like 1/5 saline, or what we call quote unquote the peat solution, these hypotonic fluids are more likely to leak. Remember, they are more likely to leak. So it's the isotonic fluid which is more likely to stay in the vessels, in the state where the capillaries would be leaky in the leakage phase or the critical phase. So normal saline would be the fluid of choice in vast majority of them. If for any reason you think that the child is hypoglycemic, you can add 5% dextrose to normal saline, what we call the dextrose saline. And in younger kids, you give them less than 6 months of age, you give them 5% dextrose with half saline. So that is about the fluid a bit that Dr. Arshad and Dr. Vajia asked. Dr. Shabat.
Thank you so much, sir. Sir, there is a very interesting question from Dr. Vajia, and if Dr. Fahim can answer it, that is thrombocytopenia must? In this wave, have seen patients with symptoms of dengue, but thrombocytopenia, but antibodies positive. And if any of the experts have experienced this also.
Okay, thank you very much. As we go back to pathophysiology, there are two pathophysiologies working on that. One is bone marrow suppression, the other is consumption coagulopathy. So this is the feature, and as we have gone through the definitions, the thrombocytopenia is included in the case definitions. So I think we should take into consideration the thrombocytopenia as well.
Thank you so much, sir. And there is a question from Dr. Asma Ashaq. Can the rash also be seen during febrile phase? Sir, Professor Harun, if he can answer this, please.
Right. So what I talked about is what we call the recovery rash. This is a very peculiar rash. However, remember, various types of rashes can occur in dengue during the febrile phase, during the critical phase, and the recovery phase as well. During the initial period, they may have like viral exanthems. And if they have got significant thrombocytopenia, there might be petechiae presenting as rashes, more so during the critical phase when the platelets really goes down. This typical rash that I showed you, what we call the white islands in the Red Sea, is the recovery rash that would occur in the convalescent phase. Yes, rashes can occur in the febrile phase.
I think, Harun, there is another thing is that this rash, the initial rash, that would be that can be present in the initial phase of fever, that is in the initial 3-4 days, and the recovery, and that rash is non-pruritic generally. The recovery rash is a pruritic rash, and with that typical description which you have beautifully described.
Thank you, sir. Bahut shukriya. Sir, there were two questions about the fluid calculation, but both Professor Dr. Tahir Masood and you have already answered that. Professor Muhammad Ali also answered the question about that if hematocrit is not available, and he also already responded that we need to monitor the patient 1 hourly for that. There is a question from Dr. Muhammad Kaleem Akhtar. Sir, Professor Tahir Masood, if he can answer it, that is there any role of diuretics, especially when in fluid overload or with respiratory compromisation?
Actually, diuretics are not to be used in these situations because these can deplete the intravascular volume further, because the problem is the intravascular volume. Intravascular volume, even if there is a apparently fluid overload, that fluid is outside the intravascular compartment into the interstitial compartment or into the third space. So giving diuretics would all the more compromise the intravascular volume. So diuretics are not to be advised in these situations.
Thank you, sir. Sir, there is a very interesting question from Dr. Misbah Noor, and if Professor Muhammad Ali can answer it. Is this the only previous dengue infection that can lead to antibody-mediated enhanced phenomenon, or it can also be caused by other infections like enteric fever that have cross-reactivity with dengue antibodies? As probably dengue hemorrhagic fever is quite evident in children this time, and Lahore has quite a number of enteric acute hepatitis cases in the recent past. Sir, if Professor Muhammad Ali, please answer this question.
Right. I think there has been a big confusion between enteric fever and dengue fever. Although there are cross-reacting antibodies, but we need virus replication enhancing antibodies which can enhance the replication and viremia in dengue. And this sort of IgG are only and only produced by dengue infection, not by the enteric fever. So anybody who is having presently enteric fever, or in the past anybody having enteric fever, does not carry virus replicating enhancing antibodies. They are present only after dengue infection and few other viral infections. So please, because many a times we have seen this, that typhoid dot is positive in this patient, NS1 is positive. So is it a co-infection? No, it is not a co-infection. You have to treat dengue separately from enteric fever, and enteric fever has nothing to do with the secondary response of producing virus replicating enhancing antibodies. It has to be by dengue, previous dengue infection. But keep it one thing more in mind, that it is usually said that this is the secondary infection. Secondary means second or third infection by other dengue seroviruses, in which chances of DHF are more. But what does these antibodies do is they enhance the viremia. So they enhance the viremia, and as a result, there is enhanced inflammatory response, and there are enhanced cytokine storm. This can happen in the first infection also. So don't be misled that it will happen only in the secondary infection. It is the amount of the virus present in the blood which will provoke inflammatory response, and as a result, there will be more cytokine storm, and this cytokine storm is responsible. So storm means more IL-2 and more TNF. They are responsible for producing DHF. But it can happen in first infection of dengue. It can happen more likely in second infection of dengue, but has nothing to do with the enteric fever. So I will request, please do not confuse enteric fever with dengue fever.
Thank you, Professor. Can I a little bit add to it? And Professor
Sure.
Muhammad Ali has very beautifully described this antibody-dependent enhancement, which is especially peculiar to the dengue infection and generally seen in viral infections. That is true that this can occur in the primary infection, and that was the reason of the vaccine which was introduced by the Sanofi and approved initially, but that was the problem with that, because that when vaccine trials were done and then this phenomena was seen in patients who were seronegative, who were not exposed to previous infection. So giving the vaccine, which is the CYD, TDV, or Dengue vaccine, because this, but then if that is given to the uninfected, previously non-infected individuals, the antibody response which was there, that can lead to antibody-dependent enhancement in the new infection later on. And that was the reason that this vaccine is not recommended for the persons who are not already infected with dengue virus.
Thank you, sir. Sir, there is a question from Dr. Harun Hamid about the role of inotropes during the fluid management, and also that the initial fluid boluses has to be subtracted or not from the total maintenance fluids that the patient is being given. Sir, these are actually two questions. I combined them sort of.
This is not Dr. Shafaq, have you asked me this question?
Gigi, sir, I asked you this question.
There would be very few patients, those who have ended up late or who have got profound shock, who would require the inotropes. There was a little bit about the detail of these patients at the end. I have skipped that intentionally. The reason I have skipped that intentionally is that the vast majority would fall in the category who would improve just with the fluid management. However, those who present late or who have got profound, irreversible shock, they may benefit from inotropes. But before we give them inotropes, we need to make sure that there are no other correctable things present in them, like acidosis, I'm sorry, or hypoglycemia or hypocalcemia, that need, or bleeding, maybe overt bleeding or hidden bleeding, that need to be addressed. So a subset of patients, a very small subset of the patient, would be the ones who would not be responding to the fluids and even to the colloids. So we need to make sure that they do not have acidosis for whatever number of reasons, bleeding, hypoglycemia, and hypocalcemia. And if any of these things are present, you need to correct them so that the response to your fluid therapy can be appropriate.
Sir, there was also a question about that the fluid boluses has to be subtracted or not from the maintenance fluids.
Yes, they have to be. Yes.
There's also a short question pertaining to that how many boluses of 20 ml per kg can be used during initial resuscitation?
The total volume that is permissible of boluses before considering giving colloids is 30 ml per kg. You give 10 ml per kg of bolus 3 times, or you give 20 ml once and 10 ml twice the other time. So the permissible is 30 ml per kg. If you have given boluses of 30 ml per kg, you should not continue giving them boluses, because you would run out of your fluid quota if you continue giving them 10 ml per kg. Then is the point when you would consider giving them the colloids, because colloid would tend to remain in the intravascular volume for a little longer and would hold the fluid in the intravascular volume little longer, and you would be able to not exhaust your fluid quota during this window of critical phase, if that answers your question.
Right. Thank you, sir. Sir, there is also an ancillary question that what is the role of dextran 40 in pediatric patients, as it is being seen that they are being used vigorously in adult dengue patients. So what's their role in pediatric patients?
Professor Muhammad Ali Sahab, I would, sir, request you, although I've talked about the reason when you would get dextran, but sir,
thank you, Dr. Harun. You have already answered the question. Whoever is asking the question, if you calculate dehydration, I believe I am talking to pediatricians, so there should not be a problem. If you are calculating a deficit of 5% and you have given bolus, पहले आपने किसी ने पूछा 20 के कितने देने, भाई एक ही देना है. If not improving, next bolus will be 10. What does that mean? That you have given 30 ml per kg of the fluid, which means you have already corrected 3% of dehydration, because for every 1% you give 10 ml per kg. So देखो, अगर 5% से आपने start किया and you have corrected 3%, so ideally patient should have now only 2% dehydration left, which is nothing, which is less than the mild dehydration. But if patient is not improving after giving this 30 ml, this is a very common sense thing. Remember that if patient has not improved with 2, you believe that now patient should be with 2% dehydration, but patient is not improving. So just question yourself that where this fluid has gone. So this fluid has followed the same course, like his plasma has leaked out, like previously his patient's plasma has leaked out. This fluid has also gone out of the blood vessel. That is why patient is not improving and hematocrit is not falling. Hematocrit is rising. Now this is a time to give some sort of fluid which is not only isotonic but hypertonic, and that is your dextran 40 10 ml per kg का यहाँ पे बोलस लगाएं. Dextran 40 की जो osmolality है ये blood से 15 points ज़्यादा है. Your blood is having 295 osmolality and dextran 40 has got 310 osmolality. It will not only stay in the blood vessels like Dr. Harun said, but it has a tendency to pull the fluid back from the pleural effusion and ascites back into the intravascular compartment. So 20 ml first shot, 10 ml second shot, not improving. This is the time to give something hypertonic which can stay inside the blood vessels and can extract the fluid, can pull the fluid back into the blood vessels, and that is your dextran 40. I hope it clears. If not, you can again ask.
Thank you, sir. Sir, there is a question from Professor Dr. Tahir Masood. It's about the indications of platelet transfusions in dengue patients, that when do we need to transfuse them if needed?
Indications of platelet transfusion?
जी sir, platelet transfusions कब करनी है?
Actually, there is no absolute platelet count which would determine whether the patient would require platelet transfusion or not. This would be dependent upon the manifestations, like if the patient is in stage 3, or if the platelet count has gone very low and the patient is having bleeding. In that situation, you can transfuse the platelet. But platelet, as this was highlighted by Professor Harun Ahmed, and the platelet transfusions are generally very rarely indicated in patients with dengue hemorrhagic fever.
Sir, with your permission, can I just...
Sure.
With your permission, sir. I want to, because there has been some discussion points here about bleeding, about platelets, and these are the main misconceptions in the management of dengue fever. I would like to just take 1 minute. Please do not go after bleeding. You must have read about the recommendation of WHO from Dr. Fahim and our recommendations. Practically speaking, our guidelines are based on Thailand guidelines and Sri Lankan guidelines, and I have found them the best guidelines. And really, our guidelines are also being appreciated. Please do not go after bleeding. Bleeding is a very rare phenomena. I would again say more very rare phenomena. And the causes of bleeding can be thrombocytopenia, DIC, or hepatopathy. So one thing, please do not go. Do not go after the platelet count. It has nothing to do with anything. Then platelet transfusion has always given harm, what has been seen in the past. Platelet transfusion, as all of you know, platelet half-life is only 6 to 8 hours. It will increase the platelets only temporarily. So the indication of platelets are only and only one indication, that if there is a symptomatic ongoing bleed, it will help that patient only for few hours. That's all. The problem with the platelet is it carries a lot of fluid. Not only it will increase the platelet count, but there have been problems in the past of fluid overload. And in my experience also, I have never used platelet transfusions in any patient, and there has never been any problem. Bleeding can be with dengue fever, bleeding can be with DHF. There can be no bleeding in DF, there can be no bleeding in DHF. The bleeding does not differentiate DF from DHF. Bleeding is usually not a concern. If you see that algorithm, when your patient is not improving by giving fluid and hematocrit is falling, not rising but falling, this is the only indication at this point. If patient is bleeding actively, we advise them to give whole blood transfusion rather than giving platelets. So at this point I wanted to highlight. And another point, the previous question was regarding inotrope. Please be careful in giving inotrope. As long as your patient, any patient who is in hypovolemia, any patient, not dengue, magic fever, any patient, giving inotrope will harm him. It will cause more harm than benefit, because it will increase the contractility, cardiac contractility, but at the same time, it will cause vasoconstriction. So be careful when the treatment of hypovolemia is volume replacement and never the inotrope. When we use inotrope, keep it in mind that when there is due to prolonged shock, myocardial contractility is decreased due to ischemia. This is the time only that you have to identify, that expert has to identify, that prolonged shock lead to ischemic damage to the myocardium and the contractility is decreased. And when you are exhausted with the fluid management, as Dr. Haroon said, that you check for the ABCS, that is acidosis and blood sugar and this and that calcium. And at that time, you can start thinking that now the patient is not improving. I have repleted the volume and still patient is not improving. His blood pressure is not coming up. That is the time, after ensuring volume replacement, you should try inotrope. Please do not go hesitantly for inotrope, hesitantly for blood transfusion. Do not go hesitantly for platelet transfusion. Thank you very much.
Thank you, sir. There are a lot of questions coming in regarding fluid management in dengue. If there are any questions to all the participants of this webinar, please post them into our YouTube link, and our expert panels and our speakers will try to address them as soon as possible. Thank you so much to every one of you. I will request Professor Dr. Muhammad Ali to please give some concluding remarks about the webinar's today's activities of ours.
Oh, thank you very much. I think I want to congratulate Dr. Haroon and all his team, including yourself, for holding such a good activity, because we are really in a time of epidemic at this time, at least in Lahore. There are a lot of patients coming, and this was a very timely activity so that we can discuss certain points. At present, I will add one thing, that during the epidemic time, if you see any child with high-grade fever for between the duration of 2 to 10 days, forget about pain and this and this and that. You just please and you are not able to identify the cause of that fever, you are not unable to localize the cause of that fever, you please start suspecting dengue fever. You will not lose anything. This is my message to everyone, that in the time of epidemic, any fever during this duration of time in which you are unable to see, there is no throat infection, no gastroenteritis, nothing, you are unable to assign any cause to that fever, please suspect dengue fever. But you will do in any way. If you are not able to find out the cause of the fever, what you will do? You will go for the investigation, and CBC is the first investigation I believe you all people do for the febrile patients, and that will solve the problem. In this way, you will not miss the patients. You will not miss the patient. This is my message. And again, I am thankful to Dr. Haroon and Dr. Fahim and all this team for inviting me to this very good activity. And also, I am very thankful to my teacher, Professor Tahir Masood. Thank you very much.
Thank you, sir. Professor Tahir Masood will be happy to take your comments regarding this activity, and if anything that you want to add up.
Thank you, Dr. Shafaq. In fact, I really enjoyed this seminar. It was a pleasure to be part of this academic activity, and I must appreciate the Pakistan Pediatric Association, the Punjab branch, and Professor Haroon Ahmed for taking the lead to hold this important activity. And I'm sure the people must have benefited. There are so many things about dengue fever, and a lot of points have come up with the discussion. And I think this would have been beneficial for all the participants. And I would second the opinion of Professor Muhammad Ali that in a situation of epidemic, we must suspect that any patient who is having fever, which is not very clear, the etiology which is not clear, that one must keep in mind the dengue fever. Actually, we are faced with the dilemma of having the two epidemics at one moment. So on one side, there is COVID-19 infection. On the other side, this has emerged as obviously this was already endemic. But in 2019, we faced an epidemic, mini epidemic as well, and now we are having many patients with dengue fever, and because of the fact that people have already been exposed to the primary infection, many people must have been exposed. So in this time, the chances of dengue hemorrhagic fever are more compared to just the simple dengue fever, regardless of the fact that 90% of the patients are asymptomatic. But still, when it comes to the overall proportion, more and more patients with dengue hemorrhagic fever are being noticed. So we want to avoid that situation. We want to diagnose that condition, because as this was highlighted in the seminar, that picking up of the serious cases, that is important, and picking up of the leak time, that is important. So it's important that we are more suspicious, and we keep these patients under observation, so that we would come to know that when is the dire situation which would warrant hospitalization and warrant the treatment. And once again, I would thank the speakers for their very elaborate, very lucid presentation. And again, Professor Haroon Ahmed and his team for arranging this academic activity. And thank you, Professor Muhammad Ali. Muhammad Ali is very experienced in the dengue management. So his participation and his words of wisdom, they are always a learning activity. Thank you very much.
Thank you, sir. बहुत शुक्रिया आपका. It was very enlightening for all of us too. Dr. Professor Muhammad Fahim Afzal, we will want to have your remarks for this activity too. Sir, you are not audible to us. You have to unmute your mic.
Okay, I would like to thank for giving me the opportunity, the Department of Pediatrics, King Edward Medical University, Lahore, Professor Muhammad Haroon Ahmed Sahab, and PPA Punjab Lahore chapter. Indeed, in this epidemic era, we should not be focusing on all the signs and symptoms of the dengue fever to recruit our patient. Just the patient which is coming under the umbrella of fever for 2 to 7 days or 2 to 10 days, we should keep our index of suspicion higher to screen that patient, and probably in cases of children, particularly with comorbidities, we should be liberal to admit those patients, not to lose the patient in going the critical phase at their homes. So thank you very much.
बहुत शुक्रिया sir. And in the end, I would request Professor Mohammad Harun Hamid to please give concluding remarks for today's session. And
thank you, Dr. Shafaq. After the remarks by my teachers, Professor Tahir Saab and Professor Mohammad Ali Saab, I don't see any room for any concluding remarks whatsoever. But I just wanted to pay my gratitude and thanks to Professor Tahir Saab and Professor Mohammad Ali Saab to be the part of this activity. I think, sir, we are really honored to have you with us. And I'm also thankful to the speakers, Professor Fahim, Dr. Navera, and Dr. Shafaq. You have coordinated and moderated this session very well. So very well done. And thank you all the participants to be the part of this webinar. This was the need of the time, and I hope it was of some help to everybody. Thank you very much.
thank you so much, sir. Sir, there is a question that some people want to review these lectures again and they want to ask some more questions. So if you can kindly please pin the link to this webinar on YouTube website, so people can benefit more from it. And yes, thank you everyone for joining for this webinar.
It would be present on the YouTube channel. It would be accessible even after this webinar. And it would be open for the comments and questions as well. So we would address those in days to come as well. Thank you.
Thank you so much, sir. And thank you so much, everyone, for joining us for today.
Are we not going to have a group photo, Dr. Shafaq?
Gigi, sir, I have requested everyone, all of you are please requested to open up your videos for like maybe 1 minute, and we will have a group photo for all of us.
मोहम्मद अली साहब, सर में मुलाकात तो नहीं होती आपके सर?
Can you excuse me?
ऑन हो जाए? जी जी सर.
Still in the bed.
जी जी, no problem sir.
Thank you very much.
Sir, webinars का यही फायदा है कि you can actually impart your experience and expertise from wherever and in whatever position. So I think मुझे तो ये virtual जो है ना, मुझे तो बड़ा ये अपील करता है और इसको हमें ज़्यादा से ज़्यादा इस्तेमाल करना चाहिए.
Sure.
जी सर. जस्ट हमें 1 मिनट दीजिएगा और बाकी लोग भी ऑन कर रहे हैं. और सर, प्रोफेसर ताहिर साहब, सर थैंक यू वेरी मच.
कोविड का एक फायदा तो हुआ है, कोविड का कि हम जो ई लर्निंग है वो उसमें खासी इम्प्रूवमेंट आई है और वो
टेक्नोलॉजी में हमें थोड़ी सी अच्छा हो गया. दैट इज नाइस फॉर अस. मैं तो ये कहता हूँ, कुछ लोग शाकी थे कि हम कर नहीं पा रहे मीटिंग्स वगैरह. और मेरा तो ख्याल था कि हर आजमाइश में कुछ ना कुछ अपॉर्चुनिटी भी होती है. तो ये एक अपॉर्चुनिटी थी हमारे लिए टेक्नोलॉजी को समझने की, सीखने की, और बहुत लोगों ने बहुत फ़ायदे भी उठाए हैं. और इंटरनेशनल कॉन्फ्रेंसेस भी अटेंड किए जो अदरवाइज जाके अटेंड करना और वो सारा कुछ बड़ा मुश्किल होता था. सो दैट वाज वेरी नाइस. सो एवरीबॉडी प्लीज कैमरे की तरफ देखिएगा और वी आर गोइंग टू हैव अ फोटो नाउ. इसमें फोटो लेने में जरा
जी जी सर, आई हैव टेकन इट. थैंक यू सो मच सर. बहुत शुक्रिया एवरीवन.
थैंक यू वेरी मच.